And at this point, we'll go ahead and get started. We're really happy to have CDES with us this morning to talk about maternal health and in bringing you a session. HRSA expects us as the Primary Care Association to support health centers through technical assistance and training opportunities to ensure that there's strong access to maternal health care, particularly in rural areas. And the timing is great. Since the United Methodist Health Ministry Fund recently worked with the University of Kansas School of Medicine to release a report on the state of maternal health across Kansas. We've got Katie Schoenhant from the Health Fund to share more about that report, which is in front of you on the tables. As VP of Programs for United Methodist Health Ministry Fund, Katie is instrumental in the Health Fund's programming efforts and strategic efforts to elevate healthy moms and children through programs such as breastfeeding support and early childhood social emotional health. Katie also leads healthy congregations through the Great Plains Conference of United Methodist Churches to promote holistic health ministries. Kansas is one of 11 states who receive funding for the Transforming Maternal Health Initiative funded through CMS, and this is a 10-year project involving a lot of money. And they have Heidi Hartner, who is the director of the initiative at KDHE, who's here to share more about that, also with us today. And then presenting as well today is Brian Anderson. He is the CEO of Prairie Star Health Center in Hutchinson. He's going to share an exciting collaboration that's taking place in his community with the local hospital to ensure access to maternal health involving the delivery of babies. Brian's been the CEO of Prairie Star since April of 2015. Prairie Star has won 8 National Quality Leader Awards, including 9 consecutive Health Center Quality Awards and Million Hearts Champions. And Brian's has the uncanny ability to recognize inefficient processes and to apply unique strategies to bring the clinical and business side of healthcare together. So with that, I'm going to go ahead and turn things over to Katie and let her get things started for us.
Thank you, Mo. Good morning, all. As you can see, and I'll just make a shameless plug here. If anyone needs any additional of these, I have more here also at our office. So we have a bunch of copies of the report, but are very happy to be here with you today to talk a bit about what we learned through the maternal health report. And I'm going to go through the slides fairly quickly as far as this component of it, because I want to leave time for others. Oh, I was looking for my slide deck here. Oh, here it is. Okay. So as he said, the University of Kansas School of Nursing was kind enough to put together this report for us. After we were hearing more about maternal mortality and morbidity rates across the state, some of the different questions that we were having about access to care. Again, we're a health foundation that works across the state and really looking at identifying ways that we can help support access to care, specifically in this space. So we were trying to figure out, looking at the various types of resourcing when we talk about the perinatal and OB care across Kansas. So outpatient prenatal services, inpatient OB services, maternal and infant health providers, nurses, support services, and behavioral health services were all of the various components that we thought were really crucial to understanding how the health system looks across the state and identifying the gaps that we have currently. So one of the things that I would say that was identified, and Dr. Rice, who is kind enough to have put the report together for us, really talked about one of the misconceptions that I would say we have in Kansas is the assumption that we are not having births in the rural parts of the state, that more of them are happening in urban areas. But one of the things that she pointed out to us is per capita with the birth rates that you see the dark blue here, those 2 counties, Greeley and, who am I missing here? I can't see it. It's too blurry. Gosh, now I really can't tell. You guys know it's on the very western edge. It's Greeley. Who is it? Who knows this? Grant, thank you. So Grant and Greeley County per capita have the highest birthing rates for this state. Wow. So as we talk about the access piece, it's also really important to recognize that I think those are the importance of why we need to work through supporting the maternity care as we've seen the deserts, and knowing that we still have these gaps in services, and specifically for those per capita that have the greatest birth rates. Okay, so one of the other things that we had Dr. Weiss pulled together were around acute care, inpatient acute care. And as you can see, we have hospitals, critical access hospitals, and birthing centers that she put together. So the map looks pretty good for here, right? So we know for just access to services across that component. But as we're looking at those that are offering prenatal services and also OB services, those maps change pretty significantly. You should see most of you on the map, I hope, too, with the federally qualified health centers, and then also with the prenatal service facilities. So you'll see the FQs are the stars on there. Seems appropriate for this conversation too. And then I would also say that the other access to services for prenatal care. And as you're looking, you can already start to identify that these numbers are shrinking for access to services, and especially when we look at the importance of the OB services. One thing that we talked about too is there's a report, and it's listed in the Vigor report. I think it's on like page 30 or 31, how the further moms have to travel for services, the less likely they start prenatal care. So, and then also for OB services, the challenges with that. And I think they said for every 10 miles that it increases pretty significantly. And then when we look at behavioral health services, because we also know, did I miss one? Or did I hit place? Sorry, nope, okay. So for the behavioral health services, we recognize too that maternal depression and other components can also have a significant factor for birth outcomes, and also for maternal health outcomes for mom and baby. So recognizing where services are here. This one to me got a little more complicated, candidly, when we were looking at this and identifying who had mental health services, and the way that they mapped this was based on the location of the provider type of providers. And so that's where you're seeing these overlays of the maps. But it kind of listed out social workers. You have the marriage and family therapy, professional counselors, psychologists, substance abuse counselors, and psychiatrists. So again, you're still seeing the locations of various services. One of the things that they mentioned, that while they were accessed, there was question about who all were being covered when she called the different facilities. It varied. And so I think even then, while there may be access to services, who they're working with may not be the same population specifically for those within the maternal health space. And then this is more what I was relying on when I was saying that the distance and how crucial that is to accessing services. So one of the other things that they did was map out the distances between the facilities for prenatal services to show how far away it is. And while she was saying this map, while tells you a distance, it's also straight line distance. It's not actually to the roads. So even though it's showing you, like for instance, in Northwest Kansas where their services are, if somebody lives in a very rural part, it's not like they're going to drive a straight line. There's how many dirt roads that they have to be on. And as I was saying, for every 10 minutes that they're driving, the less likely they are to access prenatal care. And then again, for delivery, if you have an emergency, that creates a lot of barriers to accessing services. So you can see here the distance to prenatal services, and then also from that map, it really starts to get the darker blue, which is the 30 to 60 miles when you look on the OB services. And again, this was for 2023. Some of these maps have shifted some, but here you have the 0 to 15, but you can see how many more are driving 15 to 30 miles, and then 30 to 60 for the prenatal services. And lastly, so this is then Oh, here we go. So there was Wallace and Grant County. So that was one of the other pieces that Dr. Weiss pointed out again, as we were talking about those two, how far, if we're talking about distance of services, and how important that is when you really think about for those delivering. Now, we only mapped for Kansas. So we know that other groups are accessing services outside of the state, some as well. But we did want to show where we know, and they base this off of MFM. So how far away did they have access to maternity, to high level for those that are high risk pregnancies, and then for neonatal services. So these are where neonatologists and MFMs are located. So again, we have them in Wichita, Topeka, and then in Kansas City. So for most of the state, you're traveling much more than 30 miles to access services. And especially as we want to overlay those two counties of Wallace and Greeley, the challenges that presents there too. And then the other piece that we wanted to highlight, one of the other reports did OB services, but we wanted to look at family medicine services. So 4.1 family medicine physicians per 10,000, and then 3.9 per 10,000 in rural. In rural for 4.1, and then in urban counties 3.9. This is opposite of the national data, but it's the right direction for Kansas coverage. So we know that there are more serving in rural parts of the state. And then family medicine physicians provide full scope of care work for low to moderate risk pregnancies. Again, they can do, but they also have to have been trained to be able to provide those services. One of the other things that we're hearing is after a while, like you need more than one. So then to recruit within these locations, it can make it really challenging because they're not going to be able to serve all moms just by themselves. So really they would say like 3 to 4. And then if one decides not to continue to provide OB services, but is still located there, the challenges that also presents. So there's a multi-layer piece of this as far as the challenges of maternity care. And then again, you see here with OB-GYN, so this is specifically for those that have access to services for delivery, specifically for cesareans and things of that nature. 61.4% of counties do not have an OB-GYN. And there are only 330 licensed pediatricians in Kansas. So again, the specialty pieces, especially for those that are high risk, for those that have challenges after delivery. 92% of pediatric residency slots were filled in 2024 as well. So as you're looking at those maps, I think it's like important to recognize where the locations of them are, and again, where births are occurring. Then another piece of this where only 81 certified nurse midwives are in the state of Kansas. They have a full practice authority in Kansas. So that's part of the growing number of the certified professional midwives are occurring, but there's no way to track this in the same way because they're not licensed in the same format. So we weren't able to put that together there. Lay midwives are, as I said, and there's no board for their licensure. They are also, the nurse midwife is also not able to provide the operative support element. So then a lot of times they also have to bring in a physician to be able to offer those services in case there is. So there's some challenges with that piece of it as well. Anesthesia is one that Dr. Weiss talked a lot about challenges with, because again, you have to have anesthesia for pretty much most deliveries if moms want any access to medications, or also if there's C-sections that are needed. They're integral to the team, and they're highly trained in airway management, patient stabilization, initiating blood transfusion protocols, and managing patient status. And there's many of the Kansas counties are covered solely by a CRNA, which is about 44% of them are. And then the other piece here to really highlight is around maternity care nursing. It's a specialized field that requires expertise in maternal fetal assessment and care of the laboring and postpartum patient. One of the other things that we've heard a lot from Dr. Weiss and her team is just around how, because it's so specialized, many of them don't really feel that comfortable delivering, especially because many of our rural hospitals are only delivering about 20 to 30 babies a year. So they're not getting enough access to services to really be able to feel comfortable and confident in working that often to deliver babies. And they're the highest licensed member of the healthcare team on site 24/7 within the rural facilities. I think one of the last pieces that we wanted to make sure and cover here too was also for the Medicaid coverage. In 2022, 41% of mothers were on Medicaid, and the births for that. The reimbursement rate for surgical and non-surgical delivery is about 70%, and vaginal birth after cesarean deliveries is 61%. So you can see here too, if we talk about the type of births, percentage of birth on the Medicaid, and then the type of delivery that's occurring there. So I think just to highlight, we talked some of this. Maternity care is very specialized, interdisciplinary team that requires a number of different types of providers, and how important all of those are, and transport even. And then close to 30% of the zip codes in Kansas are more than 100 miles away from access to high-risk services. All levels of system of care reflect significant stress. Most of the counties have less than, family physicians. Provide full obstetrical services requires at least 2 physicians on call 24/7, and then ensuring the right maternal level of care at the right time requires significant planning and expertise. And then about 60% of Kansas counties do not have an OB-GYN. So I think those are some of the challenges that they did want to make sure that we went over with you. It was really important to kind of see where we're at as the state. And then I think a few last pieces here, and why we put in the Medicaid component is, especially for critical access hospitals, they're heavily dependent on cost-based reimbursement model based on Medicare, not Medicaid, Medicare reimbursement models. And then the hospitals offering OB services are challenged with maintaining those services while they may not have anyone that they're delivering. And so it still requires them to staff up to that level, even if they're not having patients on site regularly who are delivering. And then maximizing the maternal health workforce and teleradiography with a regionalized plan for care and services. So I think those were some of the big ones here. Oh, we'll get into that later. I'm going to skip over that. So are there any questions on the report before we move on to the TEMA stuff? I was trying to keep it quick too, so I'm sorry I ran through that fast. Okay, I'm going to turn it over to Heidi.
Sorry. Okay. All right. So TMA is acronym, of course. We all love acronyms. So Transforming Maternal Health is a grant project that the state of Kansas was encouraged to write for, and so did last year, and was one of 15 states to have received that. And so that was pretty significant. They pulled ahead on that. That grant project started in January of 2025. Runs for 10 years, so has a long life, and is $17 million grant project. And so the goals of that project, kind of overarching goals of that project, ultimately is to emphasize kind of a whole person care model, to be able to address kind of the physical, mental, social needs of a person, kind of who that person is before becoming pregnant, who that person is while they're pregnant and during delivery, and then who that person is during a postpartum phase. So being able to address all of those components of the person during all 3 of those very different phases of their life. How can we help providers think about that in a way that they can address all of those different things that person might need, in conjunction with all of the other things that Katie just shared with us that are obstacles. So this is the map The way that the grant was written, it's required that we had a test and comparison region. Of course, we would love for all of the initiatives that we're working on and implementing to be able to be put into play in our state everywhere right away, but that was not the requirement of the grant. So the requirement of the grant was a test region, this kind of like gray-blue area. So the lower half of the state is our test region, and the kind of green section is our comparison region. And then the grant was written with a rural and frontier focus integrity. And so that eliminated the 5 most populated counties in our state. It's just really hard to justify rural and frontier in those 5 counties, even though there are a lot of births that happen in those counties. And again, that was a really hard decision. The team that was part of writing this grant deliberated about what counties to include and what counties to exclude, and excluding anyone didn't feel great. But this is what we came up with. And so hopefully everything that is implemented is sustainable and we'll be able to show positive impact, and we will be able to implement everything in Arpel State, of course, by hopefully before the age of 10 years. But anyhow, I will be ready to say next slide. I'm responsible for my own slides. So there you go. So anyhow, all the work that we do in TMA, there's myself and a team of folks, the state that will be doing the work, but not alone doing the work. All of the work that we will do with TMA has to fall into one of the 3 pillars that is written into the TMA grant. And so the three pillars, I'll just go through real quick. The first pillar is addressing access, infrastructure, and workforce. And so in that top gray section are the required sections of the grant. So these are all things that we are required to build plans around and either show success at that we have implemented in our state, or show that we have developed a plan and are working towards implementation. So those are the 2 things that we have to show that are being done. So increasing access to midwives, covering doula services, increasing access to birth centers, growing the perinatal community health worker workforce, improving data infrastructure. That's both like at an internal state level and then again with our providers, and then developing and implementing a value-based payment model. And then these optional elements, covering perinatal community health workers. I'm not sure why that one is bolded, but anyhow it is. Covering certified nurse midwives and professional nurse midwives, extending Medicaid postpartum coverage, which is something that Kansas already does, and create regional partnerships in rural areas. So all of the work that we would do, that's the work that would fall into the first pillar. We also can't duplicate any work. So a lot of this work already happens in public health with initiatives that happen in Kansas. And so the TMA project does not look to replace any of that work. It doesn't look to circumvent any of that or say, well, more important, we're here now. I absolutely work alongside my partners in public health to ensure what are you guys doing that perhaps TMA could enhance or bridge the gap for. So we're working together with those departments at the state to be sure that we're not duplicating anything. The second pillar is the quality improvement and safety pillar. Kansas has a really good handle on this pillar. Of the 15 states, Kansas is definitely in the top 5 for this pillar. So that's pretty exciting. So that work is to support the implementation of the Alliance, the AIM bundles, the safety bundles, and support birthing friendly hospital designations. So this AIM bundle that is being worked on right now is hypertension. So that is, again, work that is being done and staff that implements that work every day in public health. And so we have a lot of meetings to what's happening in the state. Who are you working with? How's it going? And again, I feel like for this pillar, TMA is really going to be that bridge. How can we kind of fill the gap on you've gone this far? What can TMA do to help you cross that finish line or make it even more successful? Reach more people, reach more hospitals. And then kind of an optional item in that pillar is to promote shared decision-making between birthing people and their providers. And then the third pillar is the whole person care delivery. How do we work to ensure that we are increasing all of the assessments and screenings that go into ensuring that that whole person care model, the integrity of the whole purpose of the grant is being addressed again in that before, during, and after period of a woman's experience before, during, and after pregnancy. Are they receiving what they need from the different providers? This is where we address home monitoring possibilities, home visits, mobile health, telehealth. So this is really the opportunity to really dive into what are the unique obstacles that folks in rural and frontier areas are faced with. What are those things that are going to keep them from appointments? What are those things that are going to keep them from care? Are there alternative ways that we can really look into ensuring that if they can't get to that kind of traditional doctor's visit, what are some other ways that we can ensure that they're being seen and ways for them to ask questions? And then the optional one there is some like group perinatal care. Is there a way to get them in sort of a peer situation so they don't feel like they're going through things alone? And then this is also like a oral health care component opportunity. So all of the work that we do over the course of the 10 years will fall into one of these 3 pillars. Does anybody have any questions about the pillars or the work that goes into the pillars or anything like that? And then, like I said, this is just a slide about kind of who's going to do the work. KDHE, I work in the department, the DHCF department, which is finance department, which is kind of interesting for them to have a grant, but very programming grant. They are finance folks. And so they were like, what do we do with this? And so it's kind of exciting to help them come along on this ride and let them know that it is not just us that will be on this ride. It's going to take a whole lot of input from a whole lot of folks to do this work. And that is actually the really exciting part for me. I love having conversations about things that can happen in communities. The work that I used to do, I always used to say that when you've seen something happen in one community, you've just seen it happen in that one community. Communities are different, needs are different, people's situations are different. And so it's exciting to talk to folks in different communities about what the different needs are and how the different ways it needs to look for folks that live there, the providers that work there. And so all of these different components will fall into place. I already mentioned public health, also internally of the Department of Children and Families. And then externally, I'll have a lot of conversations, our team will have a lot of conversations with the MCOs, with providers, with the statewide maternal health organizations, and then also community-based organizations. All of those folks have a seat at the table on this project. I can't imagine doing this work without the input of every single one of these groups. Folks can't sit in an office and make decisions about communities across the state and have them be successful. And so I really look forward to, I've already begun stakeholder conversations, which are just very bright conversations to kind of get a gauge for their perspective on the maternal health landscape in their area. And it's been really interesting to see what are the commonalities, what are the things that everybody's been bringing up, and then kind of what are those kind of very unique things that like, this must be kind of a unique thing for their area or from their personal perspective, depending on what they do. And so then there's going to be some different like work streams that folks will fall into to actually do the work. There'll be some steering committees over time, boards that will take place that folks will have term limits to be in, come in and out of. And I want to work really hard to be sure that the right folks are in place at the right time for the work that they do. So I've been working for the last 9 months, I guess, on building a lot of foundation to ensure that when the work hit what do they say, when the rubber meets the road, there's actually some impact that can happen so that folks can really see some difference when it comes down to it. So, does anyone have a question? That was all really broad, but does anyone have any questions?
So before you had your screen up, which showed your test group and comparison. So is that leading you to say, okay, now we just need to expand it, or is it just, okay, here we have apples to apples comparison, so to speak?
Yeah, over the course of time, we had to meet a minimum number of births was the main criteria. And so in our state, it's elective whether people whether providers will participate with whatever initiatives we come up with. And so we needed to boost the number of births, which is why we have that whole kind of bottom half of the state to hopefully like accommodate. We know some providers aren't going to perhaps want to do that. And so hopefully over the course of time, we'll be able to show the benefit and the sustainability of what is implemented. And that's going to be able to show that this is what we did, this is the benefit of it. And then by doing that, we'll be able to expand it into the comparison agent. So we'll have that different set of data. That's where the data piece is the
They still want to make sure your test area is an outlier.
correct. Yeah, the things that we implement have actually any difference. So yeah, there's a huge data piece that goes along within the state. A lot of like data synchronization. It's interesting to me. I'm relatively new to the state. And I just would have thought that the state had like succinct data. It's so not true. All of the departments have nearly different data, which makes like cohesive, really great data. It's not super easy. And so there's a lot of conversation going on with funding, like data lake type scenarios where there is access to consistent data for everyone to be able to report consistently so that you can get a really good hold on good information. There's also some dyad linking information that's unique to like in this situation, maternal newborn. So the like in a position situation, is there something happening with mom that would have a very like specific effect on baby? And so the physician can bring up that information. Oh, okay, I see that this thing happened with mom. I have some things I could look for specifically with the newborn. Or vice versa. Maybe the newborn got a really difficult diagnosis. And so mom's at an appointment. That information could come up on mom's stuff like, oh, I see you got a really difficult diagnosis. How are you handling that? Are you getting what you need? Do you need anything from me? So that dyad linkage, especially during that year postpartum period, where like the success of mom has everything to do with the success of baby, and the success of baby has everything to do with mom. So being sure that we can have that data linkage and that dyad linkage is part of this project as well.
So you're looking at the north and the south half of the state,
Mhm.
get comparisons. In the preparation for this grant, is there any data from different kind of rurally situated states in terms of differential obstetrical outcomes and what factors that might already be known from one state to the other?
Yeah, we do have, with the 15 states, there's, of course, like work groups with those 15 states. And all the 15 states are at really different places. So it's been interesting to see like something they might have with data like, oh, you're doing this in Oklahoma, for example. So like, how did you get there? We don't have any birthing centers right now available. If you're a Medicaid recipient, you have no option but to give a hospital birth as a Medicaid recipient in Kansas right now. And so North Carolina, South Carolina, I can't remember, one of the Carolinas, was in that same situation recently. And so I was able to reach out to them and really ask specific questions. Who did you engage within your state to get that addressed and get that changed? Was that a licensing situation? What were the barriers, and who did you engage? So I was able to ask that state very specific questions because I knew that they had very recently overcome that same obstacle. So with data that exists as well. So we just kind of it's kind of a neat situation because we meet with the 15 states, not weekly, but I have access to them as often as I need to. And I've been asked questions like with our AIM bundle stuff. They're like, oh my gosh, how are you doing that? So I can relay them, connect them to the public health folks for them to be able to get that same assistance to another state that's struggling. So it's kind of cool to see because, of course, just like I mentioned, every community is different. Every state is different. And so, but it is kind of nice to see, like, show me how you did that. Talk to me about how you did that. And then that will help me figure out what I can take of that will work in my state and what I need to develop from scratch. So it's kind of a cool working relationship. Any other questions? All right. Oh dear. Is that the next one?
That's me.
So they put me last, which was good because they know I can talk a long time. And now you can do it to you half an hour or so. Oh my gosh. It's tremendous. All right. Well, because of that, to respect the time, I did put this together just more of a high level view. So I'm not going to get down in the weeds, but if you ask a question, I'm happy to get down in the weeds. So just to start, in Reno County, which is where Prairie Star Health Center is, we're in Hutchinson, Kansas. Several years ago, I told some of you in this room, I said, man, you really need to get into vision, okay? Because that was something we had done. And today I want to tell you, man, you really should get into this maternal care stuff. Not because there's new money potentially coming, but because it's a need. The need's there, and you can do it. And as someone who's been in the critical access model, as well as now the community health center model, I can tell you that there's, the sky's the limit of like what you could have, but you don't necessarily. For instance, when I was in critical access hospital model, we didn't have OB-GYNs. We were probably going to have OB-GYNs. So did that preclude us then from doing maternal health in a small town? No. So you have family physicians who deliver babies. And so that's typically what you see in the critical access model. So those of you that are a health center connected to a critical access hospital, or you're in a community critical access hospital, you can do this. You'll just do this probably with family practice only, or maybe midwives with family practices as backup. So, but in Hutchinson, we have as far as Kansas goes, we're one of the larger communities. We're obviously not Wichita or Topeka or something like that, but for 3 decades now, the only provider type that's delivered babies in the local hospital has been OB-GYNs. But prior to that, family practice providers used to deliver the babies. So we have been wanting to do maternal health for a while now, and I would say probably we were going about it the wrong way. The first thing we tried to do is we went to the hospital and we said, hey, we would like to put in a maternal health program at Prairie Star. And can you ensure that we'll get privileges? And of course, as Dr. Kraft, we were talking before this, and he said, you basically got to go away. That's kind of what we got. It's got to go away. Because we have a large multi-specialty clinic in the community, and they have OB-GYNs. And so it wasn't going to happen. So you're going to have 2 elements. You're going to have the comfort element of, well, we're just not comfortable with that. Or you, on top of that, may have the political element. So we had both. We had the hospitals kind of not comfortable with it because we haven't had family practice doctors deliver babies in this hospital in 3 decades. How can we do that? The nurses were even worried about it, right? And then we had the political element. So we had to try a new strategy. And to what these ladies have just shown, data sometimes, it's just data, and you already know we're boots on the ground. We know these things, but you sometimes have to show them the data. So what we said is, well, let's try the collaborative approach. So we worked with the local hospital to build the case, and there was some willingness there. And of course, the first thing you do is you look at your community health needs assessment. Well, I can't embellish this because we have a guy in the room that knows what's in our community health needs assessment. Maternal care wasn't a priority in our community health needs assessment. Dental was. So we're expanding dental in our community because it was a top priority, but we couldn't use the community health needs assessment. So let's look to something else. Well, KU, the hospital CEO was able to get us to where we could work with some graduate students at Kansas University, and we performed a maternal care study to, in some ways, tell us what we already knew, but now it was there, right? Here's the data. And sadly, this is what we found. Of course, what you want to do, right, is you want to identify where the women choose to receive maternity care and why. And if Matthew Schmidt were in the room, I'd poke him. He's not here, so I'm really going to poke him. But we had nearly 30% leakage. Where was that going? Well, it was going to Newton, and it was going to Wichita, mainly. Some to Salina, but mainly those directions. And it was due to perceived or real, I don't know, but either way, poor care, turnover, lack of collaboration, and poor postpartum mental health. Those were the main things that this study revealed. So now we have this in front of us. Of course, the hospital doesn't want people going past them. They want them in their beds. So if we can help in that effort, why don't? So the hospital really has been on board, but now we have the political element, and the comfort. We still have the comfort element, but the political element is the biggest thing we have to overcome. So if you have that, then you really have to figure out a way to overcome that. So how do we overcome that? So we collaborated further to build the program because now we had interest. We had interest from the hospital. They want to see this happen. They want to have the family practice model of delivering babies in the community, regardless of what the specialty clinic in town wants. They want that. So we worked to build synergies through collaboration, and we did joint recruitment. Now, what was the first discipline you think we recruited? Do you think we recruited a family physician? No, we recruited an OB-GYN. Why did we recruit an OB-GYN? We did that because we needed an OB-GYN that believed in family practice doctors delivering babies. So we needed a voice. So we actually hopped in the car together, drove to another community, and might have stole a provider from another community, but we jointly recruited an OB-GYN that believed in family practice doctors delivering babies and would be happy to back them up and perform the procedures that family practice doctors don't perform: hysterectomies, cystectomies, ablations. So, and we need that at Hutchinson because we have those procedural things that family practice docs are just not going to do. So anyway, we were successful in getting that position recruited, and then we started to build the case further. And then you get a voice on the medical staff, because how do you get privileges in a hospital? Got to go through med staff, right? So we went through med staff, and then it gave Prairie Star the first opportunity. Prairie Star's been around 28 years, not as Prairie Star, but first time in 3 decades. Prairie Star may very well be the first clinic to have a provider deliver a baby in Hutchinson Regional. The reason I say maybe is because it also opened the door for Hutchinson Regional to hire a family practice doctor. So it's a race. But either way, we're going to be delivering babies there for the first time in 3 decades. So we then were able to go, with the help of Kansas Recruitment Center. I think I saw Joyce in the room. We were able to, with the help of Joyce in the game, to reach out to a provider in Boise, Idaho, that's from Norman, Oklahoma, that has a husband, that her husband's from Kansas City. Where's that put Prairie Star? In the middle. So that was the first thing that was important to this provider, was being between family. But then also too, we needed to look at how can we sweeten the pot to get that provider to come to Hutchinson, Kansas, instead of go to all the other places that want them. And so that's where you want to continue to collaborate on how can you sweeten the pot. Well, we know that we have limited resources in our health centers. So they're going to have to do call. So we were able to get the hospital to pick up the call rotation. They did a separate contract provider, and the provider's going to do the call rotation under contract with the hospital, and they're paying for that. They're also going to pick up the malpractice that goes under that contract. So that none of that's on us. And then we were even able to get them to do a housing bonus, a $50,000 housing bonus. We probably couldn't do that. So this sweetens the pot. So I just kind of wanted to go high level as you work through this, build the case, figure out if you have the political component, because if you do, you're going to have to take a different route. So we hired a shared voice that gave us a voice. Then we were able to hire our own physician. She starts in October. She's also fellowship trained in obstetrics. So she has that 1-year fellowship. And then, how did we get her here? I think we would have got her here regardless. But see, here's the thing. The bonus is you have to live in the community. And we all know statistically, if you can get them in your community, you've got a better chance of keeping them. So then the last thing I would bring you to is the FTCA considerations. Now, if we had paid for the call rotation, the coverage of the hospital, she would be fully covered under the FTCA for patients that are on ours, because the hospital requires her to be in the call rotation. But because she's on a separate contract, they have to provide a malpractice policy under that separate contract. But any babies that she delivers under that are Prairie Star, from Prairie Star patient, that's covered under the FTCA. So I went through that and made it sound fairly simple. It really isn't that complicated. It takes a bit, but you can do it. And I would encourage you to go through a process like this, because I know some of you talk to me and you're interested in bringing maternal care to your clinics. let's face it, if you can bring a maternal care to your clinic, you're going to help a population that struggles to get that help. And then on top of that, you're also going to be able to capture more of that pediatric population. Because if you don't have the maternal care program, what happens to the kids that are delivered as a result of, let's say you take care of mom, but you may not pick that child up because a pediatrician from a competing facility may have a child come to their facility. So anyway, so those are just some quick things going through here. And I would add that I think many of you know this in the state of Kansas, right? We've got the Smoky Hills Family Medicine Residency Program in Salina that Dr. Kraft is involved in. And they churn out very solid physicians that, guess what? They're trained how to deliver babies. So they're out there. And I will tell you, we're kind of in a spree right now where they all want to do it. So some of you say, how do you recruit these physicians? Well, I'll tell you right now, it's easier to recruit a physician if they can deliver babies. It's harder to hire a physician, a family physician, if you don't have that opportunity for them. So that's just something else to put on brain. So that's just a quick breakdown, trying to stay in 10 minutes, which I think I did. So I don't know if there's any questions for me.
I just want to add, I appreciate Brian coming and sharing, that experience. I think it was an opportunity, just to hear how it worked at Point B. Again, we've heard from many sessions that it's not always going to work the same way, but at least it gives you some food for thought on how it worked. I do have a follow-up question, though. What would you say was the time frame from assessing the need to hiring the person?
So this actually played out from March of last year to she'll be in place this October. Now, KU they got on the recruitment center, found us the candidate. Now, let's face it, if we hadn't come up with the right candidate, and we did, you don't need a fellowship trained family practice doc. Okay? Dr. Kraft shaking said, yeah. But because of the political nature of our situation, because I even talked to Dr. Kraft about one of his residents there that I would have loved to have, but the political nature of our situation, we went with the fellowship training. But there are tons of Via Christi program, Wesley program. Well, probably Via Christi, but Wesley also, and then the Smoky Hills family. So there's a lot of availability, and these kids are looking for places to go in Kansas. So, but yeah, that's how long from last March to October to get our own person in place. But we had the OB-GYN in place by August. So that was also probably remarkable. Thank God was looking out for us. Thank you.
So we do have time for more questions for Brian, for Heather, or Katie.
So hi, I'm Tiffany Swanson. I am the CHO at Health Partnership Clinic, which is an FQHC in Aretha. I'm also an OB-GYN. I love what's being done to address the maternal care deserts. We have kind of a different problem at our clinic. Over 50% of our patients are uninsured. Our issue isn't that they don't have access to the care, it's that they cannot afford it. And I'm just wondering, is there anything being done to address that? Like, how am I supposed to help my high-risk moms when they can't afford the FFL, they can't afford the ultrasounds, they can't afford the baby scans? I just wanted to throw that out there, but that's something that we are really struggling with. And I think a lot of that has to do with Medicaid expansion and all of that. But just kind of wanting to get that out there and seeing if anyone has any feedback.
I mean, your clinic just, I don't know what level they can't afford, but you've heard this, that your clinic just has to be willing to slide. They have to be willing to slide that care and make it affordable because there's just really not other options. I mean,
So the issue is, like, we don't have radiology, we don't have perinatalologists.
Oh, okay, yeah.
And so they have to go to
Okay,
KU
I
or
wasn't-
wherever, and KU does have a financial assistance program, but they can't afford it.
Yeah.
So then they're just not getting that care that they need and they deserve, which is then increasing the rate of overweight babies and NICU stays and all of that. So I don't know, there's anything I can do to advocate for that or talk to anyone about that, I'd love to do it. I just don't know where to start.
Well, in Salina, I mean, we've had kind of a history of our local hospital does cover a lot of that stuff for sure. Now it's not the same burden in terms of the numbers that I think you're talking about. But it does require people who have, or organizations that have some resources to do some uncompensated care. And then we use the maternal fetal medicine program out of Wichita. I don't know the exact details necessarily of how from like the cost, but feels like they have access and are able to afford it, at least enough that they access good services. So no, Wichita, Tennessee to talk and figure out like, well, Wichita can do it, hands in hands.
Yeah, I think something that we run into on Hayes, our slide is different than Hayes Med's slide. And when we had our site visit, that was something that was brought to our attention is that, okay, we're all looking at the federal poverty level and we've got this and that. The requirements, of course, of the FQHC, anybody that walks through our door is our patient. We don't ask questions. One of the requirements that Hayes Med for their low-income slides, whatever write-off is American citizenship. And so that's what Persa said. We need to reach out to Hayes Med, ask them, can you change your slide so it is more like what Persa would like to see? You can make the ask. Sometimes the answer is no.
Unfortunately, those problems exist even to get a colonoscopy. You know, it's just, we struggle, you know, we need someone to get one. In our community, you know, the multi-specialty clinic, they won't do it. It's non-paying patients. So yeah, I feel your pain. We don't have a solution for a lot of other things as well, so.
I would offer a suggestion. It might be worth a conversation with the hospitals to ask them to maybe contribute to maybe a sort of a voucher program that can be directed to those patients, because otherwise those patients are going to end up in their emergency rooms. So maybe they might be willing to establish some sort of fund that you would commit to using to support the care for those women who need that service.
Which we need a voucher.
I feel like you're using, like leveraging community benefit dollars or something.
Exactly. Any other questions?
I would add to part of this conversation is a little self-serving on the part of community care. As the PCA, HRSA has directed us with some funding to support the health centers and how to better address maternal health care. And so part of this was kind of initiating that conversation. And because we knew there was already so much work going on in the state on this topic, we didn't want to pull another brief together and try to figure out who we need to talk to. So we want to keep these conversations going with these folks who are already doing this work and then figuring out having the health centers be part of those conversations, and then how can you be using this information, these resources, these opportunities to improve that access.
I think I did have one question about the grant, transforming maternal health. So I am aware of our mom's grant, that rural maternity and obstetric grant that it's my understanding that the Sunflower Health Network is participating in, which is a network of hospitals in Northwest Kansas, specifically to try to improve maternity outcomes. I guess I would maybe ask from a research standpoint, is that on the radar as a potential confounder? Because that's mostly in the northwest corner. If they're wildly successful, could that influence the balance of outcomes that you're seeing in your test area? And are you aware of what they're doing and the things that they're trying to do?
I mean, I haven't had a specific conversation with them to see. There's a million conversations to be had. And the unique thing about this grant is there's a 3-year pre-implementation period of the 10 years. So these 3 years are like information gathering. So a lot of times when you receive a grant, it's like, how quick can you spend the money? Time starts right now. With this one, I've got 3 years to hold conversations to figure out what is happening, what needs to happen before year 4. Do a little math there. For, through the end. So during that time I'm having all these conversations with what's happening. What are you doing? We don't want to duplicate any efforts. If there's success that's to be had in the comparison region, fantastic. Like that isn't going to be viewed as anything negative at all. Success is success. So I don't think that would be viewed as bad. I just want to have the conversation about what's being initiated that's successful and how can that be implemented wherever possible. Another unique component to TMA is that there are incentive payments that can be utilized for providers through this grant in years 3, 4, and 5 to help position them, because we do know that dollars are a lot of times what keep providers from being able to be successful, to entice that person to come to the middle of nowhere, Kansas, or build that infrastructure to be able to change the way you kind of treat patients or, whatever that is. So there is some infrastructure payments that are built into TMA to be able to provide providers. So it's not program dollars, it's more like infrastructure dollars.
So I saw in your slides that your focus is on providers with less training. Are there going to be, in that years 3, 4, 5, are there going to be monies that are available for providers with more training?
Sure, it's not exclusive to any kind of provider. It's open to any kind of provider. I think there's just unique focus and call out on there could just be extension of providers, the provider network. So casting a large net, you're going to get more folks that might be interested in being those kind of periphery providers rather than I'm going to go to med school.
I think it's building out a more robust care team. We're taking advantage of existing providers to strengthen the team, the capacity of the team, and making sure that payment incentives are aligned with having a broad care team. So I think it would actually falls into a lot of ways to bridge partnerships, I think, between FQHCs and hospitals. Like, how can you have, like you guys are doing, shared teams? You guys, there may be some financial incentives there. So, right now we're on the front end of reimbursing for doulas, but that's not the answer to everything. But like, what could the care team look like, knowing it's harder?
Well, like in our situation, we're carrying family practice with OB-GYN, which hasn't been done in 3 decades, right? So, whereas in other communities, maybe with midwives, with physicians, or
I mean, that's why I alluded to, like, each community is going to find a unique way to fit what their community needs and is comfortable with. So this grant doesn't limit what that payment is or what that reimbursement is. It's just how can we get as many people to this as possible to provide the care that's needed. So.
And I think to Dr. Kraft's point too, I think with the RMOM's grade specifically, from what I'm understanding, that they're really providing is, some of what I mentioned on the nursing components, right? Like having access for them to come to Salina to learn more about how to provide those services and to help with training. I think some of the other ones are also looking at ways to help support. Well, and there's the KU Care Collaborative one too, that's also working on trying to expand for those who are not delivering that often to be able to have access to better understanding of how to provide those services, as some of them are doing in emergent situations. So I think to me, all of that will bridge some of it, but I still think that the reality is the number of providers, all of the different pieces, I think it's going to take a broader care team to be able to support it. I think that was one of the other things we had talked about, and it was on my last slide that I didn't really get to, is that continuity of care. So I do think that the FQs are such a crucial piece to that as well. How do we look at prenatal supports and then helping with that coordination to the providers and then also postpartum? So you all are, even if you don't have a partnership with the hospital to be able to provide the services, how are you providing that wraparound support? So I think those are some of the other really crucial pieces of this that we know, the earlier that people are having services and also having those provider groups to be able to look at the various pieces. But I think to David's point too, the doulas or what other community health workers, whoever else that could be providing additional supports and wraparound services when we know that we're already stretched so thin for medical providers. Like how do we expand the care team in ways that help support them so that if you don't have more than 2 or 3, like, so that they might have a little bit of a break. We're not saying they're going to have a full break.
There's a tipping point there.
For sure.
In terms of like being able to support obstetrical services in a hospital. And there's kind of, I don't know if it's really a true experiment, but kind of a natural experiment that I've seen in my mind out in western Kansas between Sherman County and Thomas County, where some of our graduates have gone to, that for whatever reason, and I don't know all the factors, Colby has decided to try to have a core of delivering providers. And what that has done for their program and their community and the medical facilities, their new hospital that's right in there, compared to what's happening in Goodland, where we've had graduates of our program go to, but that carrying capacity and that tipping point where, okay, we have enough providers who can actually have a delivery program that sustains itself, draws in patients. That seems like it's happened in those 2 counties in very different ways.
Yeah, I look at this like, whenever you implement a new software system, you never want to do the beta test site. Well, what you talked about out west, Sherman and Thomas County, what's happening with Bryant. I see you guys be awesome. Because if this model works and we now can show that, because Hazel, a lot like Hutchinson, about the same size, but it works there, we can tweak it to make it work here. And so, no pressure, just be awesome.
Well, when I was in the critical access model, this, and Dr. Krabbel's going to talk about, this makes physicians uncomfortable when you say these kinds of things. You're in a bigger town, but when you're in a critical access model, going back to those days, you don't have you're in a town of 2,242 people. You don't have all those other resources there. You don't have all the subspecialists down the hall that you can ask questions to. I've seen PAs on FaceTime with a trauma surgeon in Wichita, and they're telling them what to do, and they're doing the scariest stuff right there in the critical access hospital, because otherwise they're going to die. I think we all have to remember that it depends on where you're at, and you need to make it work where you're at. So this will be under extra scrutiny because of the political element. If there were no political element, I think this is for sure a success. But we'll make it work. We'll try to keep it proud.
Yeah. Just since you asked us, be excellent.
We're proud. I appreciate it.
Well, and then I think the other piece that I know with the TEMA stuff is really that enhanced payment components, because I think the other thing that has been recognized for most of the hospitals is they're losing money by upgrading babies. And so trying to figure out how, especially for the critical access hospital, I'm sure Brian can speak to that too, like you're not making money off of delivering. Most of them are doing it because they know the need is there so much, and then also just for the community part of that. So I think those are going to be some major pieces of the team at Brand to figure out as well for sustainability for these services.
Well, the encouraging thing is that, everybody's aligned. Like, I had a meeting with the MCOs in Kansas, and they were all like, absolutely, where can we fit it? What work stream are we supposed to sign up for? Like, there was no hesitation for the folks that I was on the meeting with. And, they want to be involved. They want to make sure that the work they're doing is impactful. And I know that hits differently for everyone. But there seems to be, it's important for all the folks that are involved. And it's been nice to see that there's alignment in making this happen, to the encouragement to write the grant, to get the grant, to seeing it play out to fruition. like Flagship excited to be part of it. There's a lot of momentum, as we know, with all the projects that are happening. So I hope that Tima and all the other things that are happening can be some like bridging of efforts. However, so if there's a conversation you want to have more, thinks there's somebody I should talk to, let me know. That's what I'm in the phase of. A couple of years of conversations. I love a good conversation. So hit me out or send me somebody that you think I should talk to. For me first, anyway.
Well, on that note, thank you, Heidi, Katie, Brian. I appreciate your words.